I remember the week before exam 2 like it was yesterday. A tidal wave of notes, flashcards, 3 different question banks shouting for my attention. You do not need to drown in details to pass. You need a map that highlights the high-yield landmarks. Today we are doing a surgical, efficient pass through GI, GU, reproductive, endocrine. The exact things that will give you the most return for your time. This is not about memorizing every enzyme or ligand. It's about building a cue-cause system framework, so that when a vignette lands in front of you, you instantly know which mechanism to anchor to. I'll give you crisp, exam-minded summaries and the specific cues to watch out for. Think of this as triage for your brain before the test, We'll move fast, but we'll be strategic, real clinical signs. Underlying pathophysiology, one-line exam takeaways you can pin to your mental bookshelf. By the end of this video, you should feel calmer, more focused, and ready to answer exam 2 questions without overstudying. Quick mastery review. GI, GU, reproductive, endocrine. Burning chest pain gets worse when you lie down. That's your classic clinical cue for reflux. Think of the lower esophageal sphincter, LES, as a door. When it's weak or relaxed inappropriately, gastric acid escapes up the esophagus. Positional heartburn, often after meals, regurgitation, sour taste. That's the symptom level. The cause is failure of the LES to maintain a barrier. Acid exposure injures the esophageal mucosa, causing inflammation, sometimes erosions. Those cues point to GERD, not cardiac pain, not motility disorders. Lifestyle change, PPIs, or fundoplication if severe. Anchor, cue, positional heartburn, cause, LES weakness. System, acid-induced esophagitis, epigastric pain and nausea. Those are the hallmark cues for gastritis, especially when they're temporally linked to NSAID use, alcohol, H. pylori exposure. Jaundice and dark urine are high-yield cues that scream hepatobiliary dysfunction on an exam stem. When the liver can't properly conjugate or excrete bilirubin, it accumulates in tissues and the urine becomes dark from conjugated bilirubin. Prehepatic causes, hepatic causes, post-hepatic causes. The exam will often nudge you toward one by adding hemolysis labs or cholestatic enzymes. Hemolysis increases unconjugated bilirubin, hepatocellular injury bumps, conjugated bilirubin, bile duct obstruction bumps, conjugated bilirubin, and raises cholestatic enzymes. If they give you transaminase dominant labs, think hepatocellular hepatitis. If ALK-Phos is high, if conjugated bilirubin is high, think obstruction, think cholestasis. System-level consequences include coagulopathy, hypoalbuminemia, and portal hypertension in chronic or severe cases. Jaundice, plus dark urine, conjugated process likely, transaminase pattern, hepatocellular, cholestatic enzymes, obstruction. That route helps you pick the right diagnostic or management step quickly. Inflammatory bowel disease splits into 2 classic exam-friendly patterns: Crohn's, skip lesions, potential malabsorption, ulcerative colitis, continuous colonic inflammation, bloody diarrhea, urgency. If the vignette mentions transmural inflammation, fistulas, perianal disease, you should be thinking Crohn's. Crohn's can affect the entire GI tract. Strictures, malabsorption. UC is colon-limited with increased colon cancer risk over time. Q, skip lesions. Q, transmural inflammation. Q, continuous bloody diarrhea. Cause, immune-mediated inflammation affecting different layers and distribution system. Malabsorption, Crohn's. System, fistulae, Crohn's. System, strictures, Crohn's. System, toxic megacolon, UC. System, colorectal cancer risk, UC investigations. Colonoscopy distribution. Imaging for fistulae. Long-term surveillance. Left lower quadrant pain and fever in an older patient is a classic exam cue for diverticulitis. Diverticuliform where the colonic wall is weak, stool gets trapped, bacteria overgrow, localized inflammation or microperforation follows. Fever, elevated WCC, and tenderness on exam. CT, paracolic fat stranding, possible fluid collections. Outpatient antibiotics for mild disease, admission and drainage, or surgery for complicated cases. LLQ pain, plus fever. Trapped stool causes inflamed, infected diverticulum, paracolic inflammation, abscess, possible perforation. Severe upper abdominal pain radiating to the back, particularly left upper quadrant or epigastrium, that improves when sitting forward is a classic flag for pancreatitis. The cue is severe, constant pain with nausea and often elevated pancreatic enzymes. The cause is activation of pancreatic enzymes within the gland, essentially autodigestion, which then triggers a systemic inflammatory response in severe cases. Common triggers you'll see in vignettes include gallstones obstructing the ampulla, heavy alcohol use. Imaging can show an enlarged, edematous pancreas. Complications: pseudocyst, CIRS, multi-organ failure. Q. Severe, leukoepigastric pain radiating to the back. Cause: premature enzyme activation and autodigestion. System: inflammation and potential systemic complications. Treat with aggressive fluids, pain control, and fix the cause like gallstones when indicated. Hypertension: palpable or enlarged kidneys suggest polycystic kidney disease, particularly in a younger adult with a family history. The cause is genetic mutations leading to cyst formation that gradually replace functional nephrons. The system-level consequence is progressive renal failure with secondary hypertension driven by renal ischemia and RAAS activation. Extrarenal findings like hepatic cysts or Barry aneurysms may also be tested. Watch for headaches or family history of aneurysmal rupture. Q. Hypertension and enlarged kidneys. Cause: numerous cysts replacing normal renal tissue. System: progressive chronic kidney disease with associated complications. Fatigue and anemia in a patient with abnormal creatinine or long-standing kidney disease points you toward chronic renal failure. The cues are nonspecific paired with elevated blood urea nitrogen, creatinine, low glomerular filtration rate. They become diagnostic. The underlying cause is cumulative nephron loss, reduced renal clearance of toxins, impaired endocrine functions. Toxin buildup causes uremic symptoms. Reduced erythropoietin production leads to normocytic normochromic anemia. Secondary hyperparathyroidism from phosphate retention and hypocalcemia shows up as bone pain or fractures. Q. Fatigue, anemia, elevated creatinine. Cause: nephron loss, reduced renal function. System: toxin accumulation, anemia from low erythropoietin, mineral bone disorder, pointing to dialysis thresholds, transplantation discussions, and complication management. Severe colicky flank pain often radiating to the groin with hematuria. Classic cue for nephrolithiasis. Think obstruction, crystals forming in the urinary tract, spasmodic pain as they try to pass, irritating the ureter lining. Calcium oxalate is the most common. Uric acid, cystine, struvite. Use clues like acidic urine or infection history. System-level problem is obstruction causing hydronephrosis and, if prolonged, potential loss of renal function or infection upstream. Q. Severe flank pain and hematuria. Cause: crystal formation and ureteral obstruction. System: hydronephrosis, infection risk, renal impairment. That guides non-contrast CT, analgesia, and stone-specific management. Distinguishing a lower urinary tract infection from pyelonephritis is one of those exam staples that boils down to local versus systemic cues. UTI typically gives you dysuria, frequency, urgency, localized suprapubic discomfort. Pyelonephritis adds systemic signs: high fever, chills, flank pain, nausea or vomiting. Cause: UTI, ascending bacterial infection confined to bladder mucosa. Cause: pyelo, infection ascends to renal parenchyma producing inflammatory injury and systemic response. Lab cues: pyuria, bacteriuria. Pyelo, higher white cell count, fever, abnormal renal function tests, possible. For exam quickness, Q, dysuria, only versus dysuria, plus fever and flank pain. Local symptoms versus systemic inflammatory response, potential sepsis, outpatient oral antibiotics or hospital admission and IV therapy. Reproductive disorders show up in exams as pattern recognition, irregular cycles and hirsutism, PCOS. Cyclical pelvic pain tied to menses, endometriosis. Fever with pelvic pain after intercourse or IUD, PID. Urinary hesitancy in older men, BPH. Absence of a testicle in the scrotum at birth, cryptorchidism. Each cue maps to a clear cause and system-level problem. PCOS. Hyperandrogenism and insulin resistance causing anovulation and metabolic complications. Endometriosis. Ectopic endometrial tissue causing cyclical inflammation, adhesions, pain. PID. Ascending infection. Watch for cervical motion tenderness, risk of infertility and tubo-ovarian abscess if untreated. BPH. Age-related prostatic hyperplasia, bladder outlet obstruction and urinary symptoms. Cryptorchidism. Failure of descent risking infertility and malignancy later. Keep Q, cause, system front and center. Symptoms suggest the pathology. Pathology explains the mechanism, and mechanism predicts complications and management on in-exam decisions. Diabetes exam stems often hinge on distinguishing absolute insulin deficiency from insulin resistance. Type 1 typically presents in younger patients: polyuria, polydipsia, weight loss, diabetic ketoacidosis. Autoimmune beta cell destruction equals negligible insulin. Type 2 usually occurs in adults with obesity, metabolic syndrome. The body makes insulin but tissues don't respond effectively. Type 2 causes peripheral insulin resistance with relative insulin deficiency over time. System consequences: hyperglycemia, mediated complications, microvascular issues like retinopathy and nephropathy, macrovascular risk, atherosclerosis. But the path differs by type. For rapid exam decisions, Q, cause, system simplifies choices. Q, young, acute presentation versus older. Metabolic risk factors. Cause, DKA, fruity breath, plus, small breathing. Thyroid, hyper, fast metabolism. Hypo, high, slow metabolism. Adrenal, Cushing versus Addison. ADH, PI, high, dehydration. SIADH, high, fluid overload. Quick exam, 3 preview, Hemi, don't memorize randomly. Match cues, cause, system. That's how questions are written. Quick mastery review complete. Pass exam, too fast.